Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Right. And today we're getting into some incredibly dense, frankly vital material.
Yeah, so picture this. It is 2:00 a.m. A 78-year-old falls from standing in their bathroom.
A classic scenario.
Right. They arrive in your bay, perfectly stable vitals, a GCS of 14, slightly confused but tracking. But, and here's the kicker, they are on a Pixaban.
Oh, yeah. The modern trauma night noise.
Exactly. And by the time you get that non-con CT back from radiology, that supposedly minor subdural has expanded their GCS tanks to an 8, and suddenly you are completely behind the 8 ball.
You're fighting a secondary injury cascade that is actively destroying neurons by the second.
By the second. And that exact scenario is why we are tearing into the definitive texts on this subject today.
Yeah.
We're looking at traumatic brain injury, clinical management, and surgical intervention, alongside pathophysiology, diagnosis, and early care by Wilson, Hof, and Couture.
Yeah, these texts are, they are the absolute gold standard right now.
They really are. And we are bypassing the standard ATLS rehash today. You already know how to run a trauma bay.
Right. We're not teaching you how to put in a chest tube here.
No. We are taking the dense data, the controversial trial methodologies, and the conflicting pharmacological protocols, and extracting the absolute highest yield evidence to dictate your next move.
Because the demographics, well, they've completely shifted under our feet.
They have. So let's talk about the roadmap for this deep dive. Where are we going?
So we are moving sequentially. We're starting from pre-hospital and initial emergency department resuscitation that will transition into advanced ICU neuromonitoring, and finally we'll get into the operative thresholds and surgical techniques.
All the way to the OR.
Exactly. And the overarching goal here, the thing you have to keep in mind for every intervention we discuss today, is avoiding secondary brain injury. That is the ultimate goal.
Let's start with that demographic shift you mentioned, the epidemiology.
Yeah, if you look at the CDC numbers from the last decade, we're looking at a $70 billion annual societal burden.
70 billion.
Right, with TBI contributing to a full third of all trauma-related mortality in the U.S.
But the face of that mortality, it's not who it used to be.
No, it's really not. It's no longer just the 22-year-old ejected in a high-speed rollover. The massive severe spike in TBI hospitalizations is squarely in the demographic of adults over 74 years old.
Ground-level falls have literally overtaken motor vehicle collisions.
They have. And the physics of that are just brutal.
Let's look at the anatomical vulnerability there. Because, a 20-year-old takes a punch to the head, and their brain parenchyma is flush against the dura.
Right, it's a tight fit.
But in our 78-year-old on a Pixaban, we are dealing with severe cerebral atrophy.
And that atrophy fundamentally alters the biomechanics of a low-velocity impact.
How so?
Well, as the cortical volume decreases, the physical subarachnoid space between the cortex and the dura mater widens.
So there's more physical distance.
Exactly. And the bridging veins, which are responsible for draining the underlying neural tissue into the dural venous sinuses, they're now spanning a much larger gap.
They're being stretched.
Right. They're under constant baseline traction. They're pulled taut like guitar strings.
So the tensile strength is already compromised before they even hit the floor?
Precisely. The threshold for avulsion drops precipitously. The kinetic energy from a simple slip in the shower,
which might not even cause a scalp laceration,
creates enough rotational shear to snap those bridging veins.
And now you have a venous bleed.
Right. But the real trap for the trauma surgeon isn't just the bleed. It's the delayed clinical presentation caused by that same atrophy.
Because there's so much dead space in the cranial vault.
Exactly. The hematoma can expand significantly, sometimes accumulating 50, 60, or 70 cubic centimeters of blood before it ever starts actively compressing the viable brain tissue.
Before it even touches it.
Right, and before it starts raising the intracranial pressure. In a young patient, a 20 cc bleed spikes the ICP and drops the GCS immediately.
They show you the injury right away.
But in the elderly patient, the volume accommodates in that empty space. By the time they show you a clinical sign like a blown pupil, posturing, or that drop to a GCS of 8, the absolute volume of blood is massive.
And the uncal herniation is already underway.
It's too late.
Combine that massive accommodated volume with the fact that half these patients have therapeutically inhibited coagulation cascades, and the triage calculus is just a nightmare.
It really is.
Okay, let's unpack this. Before we get to the specific tag profiles and reversal protocols, let's establish the fundamental physics of the vault.
The Monroe-Kelly doctrine.
Right. We all know it, but practically manipulating it in the bay is where the edge lies. I still like the rigid pelican case analogy here.
It's a great analogy.
The skull is heavy-duty plastic, completely sealed. You've got brain, CSF, and blood in there. You add a 50 cc subdural hematoma, 50 cc's of something else has to exit the case, or the pressure curve goes vertical.
And that pressure curve is critical to understand because it is not linear. It's exponential. Initially, as that subdural expands, the body compensates beautifully. It auto-transfuses CSF out of the basal cisterns and down into the spinal subarachnoid space.
Making room.
Yeah, and it squeezes the compliant venous capacitance vessels, shunting venous blood out through the jugulars. During this phase, you can add 30 cc's of blood, and the ICP might only rise by 2 millimeters of mercury.
But once compliance is exhausted,
And once you hit that inflection point on that volume pressure curve, adding even 2 more cubic centimeters of volume will shoot the ICP from 15 to 40 almost instantly.
okay, so we have a patient who is rapidly approaching that inflection point. You don't have a cranial drill in your hand. The scanner is 10 minutes away. What is the immediate non-pharmacological manipulation of that pelican case?
The single most effective immediate intervention requires zero equipment.
Zero.
It is strict patient positioning to maximize cerebral venous egress.
So you're manipulating the blood component of the Monroe-Kelly doctrine.
Exactly. You must ensure the cervical spine is in a completely neutral position. A cervical collar that is applied too tightly,
Correct.
or a neck that is rotated even 15 degrees, will mechanically compress the internal jugular veins.
You are effectively putting a tourniquet on the brain's outflow tract.
Right. You're trapping the venous blood in the vault while the arterial blood continues to pump in at 60 C. Mean arterial pressure.
So neutral C-spine, loosen the collar if it's acting as a venous tourniquet while maintaining inline stabilization, and immediately utilize reverse Trendelenburg.
Get the head of the bed elevated 30 degrees. You use gravity to assist the venous drainage out of the cranial vault, decreasing the overall cerebral blood volume.
Shifting them slightly back to the left on that exponential compliance curve.
Exactly, buying time.
Okay, we've maximized venous outflow, but now we have to secure the airway. Let's look at the resuscitation sequence, the golden window. The texts are unequivocal here. Secondary injury is driven by hypoxia and hypotension.
Those are the twin killers.
Right. An oxygen saturation below 90% independently doubles the mortality rate. It is catastrophic.
The pathophysiology there is straightforward but devastating. I mean, the brain has virtually no glycogen or oxygen storage capacity.
It's an obligate aerobe.
Yes. The moment you introduce systemic hypoxia, the already traumatized microenvironment around the contusion shifts entirely to anaerobic metabolism.
And the byproduct is lactic acid.
Lactic acid accumulation, which immediately drops the local tissue pH. That causes cellular swelling, rapid failure of the ATP-dependent sodium-potassium pumps, and a massive influx of intracellular sodium and water.
Cytotoxic edema.
Within minutes, you are literally watching the brain cells swell and die because you delayed intubation.
But securing that airway comes with a massive caveat in the neurotrauma bay. The text is highly specific about agent selection for rapid sequence intubation. We cannot afford to chemically lobotomize the patient for hours.
No, because the neurologic exam is the most sensitive, real-time monitor of intracranial pathology you have.
More sensitive than the initial CT, frankly.
Absolutely. If you paralyze a patient with a long-acting, non-depolarizing agent like rocuronium at a high dose, you completely blind yourself to an evolving motor deficit.
You won't see them posturing.
Right. You want short-acting sedatives and, if necessary, short-acting paralytics so you can establish a reliable GCS motor score the moment the tube is secured and the CO2 is controlled.
And once that airway is secured, we have to talk about hemodynamics, because the old ATLS dogma is going to kill this 78-year-old.
It absolutely will.
For decades, the trigger was a systolic blood pressure of 90. Keep it above 90, and you're perfusing. But the text completely obliterates that target for TBI.
The literature has undergone a massive paradigm shift here. The SBP greater than 90 rule is dead in severe TBI.
Dead.
The updated guidelines demand an SBP strictly above 100 for the general adult population.
But critically, for your patient over 70 years old,
The absolute floor is an SBP of 110.
110. Let's look at the evidence behind that, because the data shows a single non-spurious episode of hypotension dropping below those thresholds doubles mortality.
Doubles it.
And if it happens repeatedly, the mortality risk increases eightfold. But why the specific shift to 110 for the geriatric cohort? Why is 105 perfectly fine for a 35-year-old, but essentially an ischemic stroke for our 78-year-old?
We have to look at the cerebral autoregulation curve.
Okay, walk us through that.
So in a healthy young vascular bed, the brain's intrinsic arterioles can constrict or dilate to maintain a perfectly flat, constant cerebral blood flow across a mean arterial pressure ranging roughly from 50 to 150.
They adjust automatically.
Right. But chronic hypertension, which is practically ubiquitous in the geriatric trauma population, forces a rightward shift of that entire autoregulation curve.
Their set point is fundamentally altered.
Exactly. The vessels are hypertrophied and stiff. They are accustomed to much higher driving pressures just to maintain basal perfusion.
So at SPP of 105, which looks totally acceptable on the monitor to a junior resident,
Represents profound hypoperfusion to a brain that relies on an SBP of 150 to push oxygenated blood through those rigid atherosclerotic arterioles. You drop them to 105, they fall off the left side of their shifted autoregulation curve, and the penumbra around the injury dies.
so we know we need the pressure up, but the text explicitly warns against drowning them in crystalloid to get there.
Yeah, there is zero outcome benefit to hypervolemia.
None. In fact, aggressive fluid loading and massive pressor utilization increase the risk of ARDS fivefold.
It's a terrifying tightrope. You are trying to maintain a cerebral perfusion pressure without blowing out the alveolar capillary membrane.
Which is why you need an early arterial line for beat-to-beat MAP monitoring. You can't rely on a blood pressure cuff cycling every 3 minutes. You need precision.
You have to have that A-line.
Let's shift to the blood itself, the coagulopathy reversal protocols. We are moving away from blindly throwing FFP at a number on a standard coagulation panel.
Thankfully.
The text highlights a strong shift toward thrombolestography, or TEG, to direct our resuscitation. But as we know, the maximum amplitude, the MA on a TEG, can be highly misleading in an isolated TBI
Why is that?
because of the massive localized tissue factor release from the crushed brain matter.
That is a phenomenal point regarding the TEG profile. In massive polytrauma, you often see systemic hyperfibrinolysis. The clot is breaking down as fast as it forms.
Right.
But in isolated severe TBI, the brain tissue itself is incredibly rich in tissue factor. When the parenchyma is disrupted, that tissue factor floods the local circulation,
Triggering clotting.
often causing a localized hypercoagulable state or rapid consumption, even if the systemic TEG looks relatively normal initially. You cannot treat a severe TBI coagulopathy identical to a ruptured spleen.
And the pharmacy protocols are moving at warp speed, especially regarding the DOACs. For our 78-year-old on apixaban, we aren't waiting for a delayed hematoma.
No, the FDA has given us direct binding inhibitors, idarucizumab for dabigatran and andexanet alpha for your factors AIDS inhibitors like apixaban and rivaroxaban.
But let's look at the pharmacology of andexanet. It acts as a decoy factor ZA receptor.
Right.
It binds the apixaban with incredibly high affinity, pulling it away from the patient's actual native factor ZA. But the half-life of andexanet is incredibly short.
And that is the danger zone for the surgeon.
Tell me about it.
You push the andexanet, you normalize the hemostasis, you take them to the OR, and you evacuate the subdural. But because the half-life of the apixaban often exceeds the half-life of the decoy receptor,
It outlasts it.
you can experience severe rebound coagulopathy hours later in the ICU. The decoy degrades, the apixaban is freed, and suddenly your perfectly dry surgical bed starts microvascular oozing.
Leading to a massive reaccumulation of the hematoma.
You have to monitor anti-exhale levels meticulously post-op.
While we are fixing the blood, we have to talk about the ventilation. Here's where it gets really interesting. I want to address a practice that just refuses to die in some peripheral EDs.
Prophylactic hyperventilation.
Yes. We used to think hyperventilating the patient squeezed the vessels and saved the brain. The old thought process made intuitive sense. You bag them hard, blow off the CO2, the hypocapnia induces cerebral vasoconstriction, the blood volume in the vault drops, and the ICP number on the monitor miraculously falls.
And you pat yourself on the back.
Exactly. But the text is brutally clear about what you are actually doing to the brain tissue. Please dismantle this old practice.
You are inducing profound iatrogenic ischemia. The physiology you describe is perfectly accurate. Hypocapnia shrinks the vessels.
Right.
But by clamping down those arterioles so aggressively to fix a global pressure number, you are starving the tissue of actual oxygen delivery.
You are effectively causing a stroke to treat the swelling.
Precisely. The outcome data is indisputable at this point. Prophylactic hyperventilation independently doubles the mortality rate.
It is strictly contraindicated. The absolute rule is strict normocarbia. You target a PCO2 of 35 to 45.
The only time, and I mean the only time, you permit hyperventilation is as a desperate temporary rescue maneuver.
Like when
If the patient abruptly blows a pupil or goes into decerebrate posturing while you are physically rolling them down the hallway to the operating room for a craniectomy.
acute deterioration.
Right. Then you can temporarily drop the PCO2 to 30 to 35. It buys you exactly enough time to get the scalpel through the skin.
It is a bridge to decompression, never a prophylactic strategy.
Exactly.
Let's talk about that blown pupil because the nuances of the clinical exam dictate the triage. We all track the GCS despite its obvious inter-rater reliability flaws.
Yeah, depending on who's scoring it, you can get 3 different numbers.
Right. But the text hammers home that the motor score, the ability to obey simple commands, is your most reliable prognostic anchor, especially in intoxicated or marginally sedated patients.
It's the most objective part of the exam.
A drop of 2 points warrants an immediate repeat CT. A drop of 3 points means the compensatory mechanisms have failed and you are actively herniating.
And that herniation often presents at the pupil.
Now, the text provides a brilliant physiological distinction regarding the pupillary exam that every critical care surgeon must internalize.
Walk us through it.
Pupillary constriction is mediated by the parasympathetic nervous system via M3 muscarinic receptors located on the third cranial nerve, the oculomotor nerve.
Which is distinctly different from the receptors we are manipulating when we secure the airway.
Exactly. When you push a non-depolarizing neuromuscular blocker like zacuronium or rocuronium, you are selectively blocking nicotinic acetylcholine receptors at the skeletal neuromuscular junction.
You're paralyzing skeletal muscle.
Right, but the sphincter pupillae is smooth muscle.
Correct. It is controlled by those M3 muscarinic receptors. Therefore, standard paralytics have absolutely zero effect on pupillary reactivity.
They don't mask a blown pupil. That M3 receptor distinction is crucial, but let me pose a theoretical question from a listener. You're in the trauma bay. A 78-year-old arrives after a fall. GCS 14, slightly confused, on apixaban. Vitals are stable. How aggressive are we being in the first 10 minutes? What if they have a concurrent massive facial crush injury? They have LaFour fractures, their orbit is shattered. How are we distinguishing a traumatic third nerve palsy from actual uncal herniation in a patient who is paralyzed and sedated?
In that specific polytrauma scenario, the clinical exam is severely confounded by local orbital trauma.
It's a mess.
A direct injury to the ciliary ganglion or the oculomotor nerve in the orbit will cause a dilated, unreactive pupil that has absolutely nothing to do with intracranial pressure.
Right.
This is exactly where you cannot rely solely on the pupil. You have to correlate it with the motor exam if the sedation allows, or you immediately rely on your imaging. The unilateral blown pupil is a massive red flag, but in the setting of severe maxillofacial trauma, the CT scanner is the only way to confirm if that unticus is physically crossing the tentorium.
Which means clinical exams only tell half the story. You have to look inside the box. And that transitions us perfectly to the imaging suite.
The CT scan is the undisputed king of the acute trauma phase.
It takes seconds to acquire and is exquisitely sensitive for acute hyperdense hemorrhage and calvarial fractures. But we have to acknowledge its massive blind spot in the first 48 hours.
Yeah, the non-contrast CT notoriously misses early ischemic insults and diffuse axonal injury, or DAI.
Because it's a structural scan, not a functional one.
Right. You can have a patient in a deep GCS4 coma, and the initial CT scan looks remarkably pristine. Perhaps just a loss of gray-white differentiation or a few tiny punctate microhemorrhages at the gray-white junction.
Because DAI isn't a massive volume of blood, it is rotational shearing. The acceleration-deceleration forces literally tear the axons deep within the white matter tracts, the corpus callosum, the brainstem. But if the CT is blind to it, why are we waiting 72 hours to get an MRI?
It is entirely a matter of physiological stability and logistics.
Oh, that's so.
I mean, an MRI requires 45 minutes inside a highly restrictive magnetic tube. Attempting to manage a critically ill, hemodynamically labile patient with fluctuating ICP, multiple vasoactive infusions, and a ventilator in that environment during the acute resuscitative phase.
It's incredibly dangerous.
It's a disaster waiting to happen. The MRI is a subacute tool. You use it at day 3 or 4 to quantify the extent of the axonal shearing and establish a long-term prognosis when the patient's clinical exam remains drastically worse than the initial CT predicted.
Speaking of predicting prognosis, what about biomarkers? This has been the holy grail for a decade.
It really
The
has.
idea that we could just draw a serum lab and definitively diagnose a severe TBI within 20 minutes of injury. The text discusses S100B, UCHL1, and GFAP.
Well, the theory is sound. As neurons and astrocytes undergo necrosis or mechanical shear, they spill specific structural proteins and astroglial markers across the disrupted blood-brain barrier and into the systemic circulation.
But the clinical reality in severe polytrauma is much messier. Right now, checking an S100B level in a polytrauma patient is like trying to listen to a fetal heartbeat in the middle of a heavy metal rock concert.
That is the perfect analogy.
Yeah.
The background noise is just deafening.
It really is.
S100B is a calcium-binding protein, but it is severely lacking in strict central nervous system specificity.
Where else is it?
It is highly concentrated in adipocytes, chondrocytes, and skeletal muscle. So you have a patient with a closed head injury, but they also have crushed pelvis and bilateral femur fractures. You draw the lab, and the S100B is astronomical.
And you have absolutely no idea if that signal is screaming from a devastating hidden intracranial hemorrhage or if it is just reflecting the massive soft tissue destruction in the leg.
Precisely. It's totally confounded.
What about GFA?
GFAP is showing much better CNS specificity and actually has FDA approval for evaluating mild concussions to rule out the need for a CT.
Oh, wow.
But their predictive consistency and actionability in severe multi-system trauma remains highly questionable. We are not making operative decisions based on a serum biomarker today.
So what does this all mean for the surgeon talking to a family at 2 a.m.? Predicting TBI outcomes feels like reading tea leaves. We score what we see on the imaging.
Right.
Let's talk about how we scored that imaging. We grew up on the Marshall classification, but the text pushes us toward the Rotterdam CT score. Why the shift?
The Marshall score is highly reliant on the presence of mass lesions and midline shift, but it lacks dynamic physiologic context.
It's too static.
Exactly. The Rotterdam score is a significant evolution. It assigns specific point values to the state of the basal cisterns. Are they open, compressed, or completely effaced by diffuse edema?
It looks at the whole picture.
It evaluates the exact degree of midline shift, the presence of epidural masses, and critically, it accounts for traumatic subarachnoid or intraventricular hemorrhage.
So it correlates much more accurately with the patient's actual risk of mortality at 6 months.
Much more accurately.
And when we look at outcome measures at that 6-month mark, the text emphasizes the extended Glasgow Outcome Scale, the GOS, over the traditional GOS. We needed more granularity because massive phase 3 neuroprotective trials were failing.
They were failing because the original GOS was too blunt. It categorized patients broadly.
Right.
The GOS splits the categories into upper and lower bands of severe and moderate disability. It allows researchers to capture subtle but life-altering functional improvements.
Give me an example of that.
Okay, moving a patient from lower severe disability, meaning they're completely dependent for daily care, to upper severe disability, meaning they can be left alone at home for up to 8 hours.
That's a huge difference for a family.
Right. It might look like a statistical failure on the old GOS, but it is a monumental victory for that family's quality of life.
And managing that family's expectations is arguably the hardest part of our job at 2 a.m. When you have an elderly patient with a devastating Rotterdam score, the text advocates using predictive models like the Wake Forest Elderly Brain Injury Outcome Calculator.
It's a great tool.
It incorporates age, pupillary response, and GCS to spit out a probability of survival independence. It's not a crystal ball, but it anchors the discussion when families are faced with agonizing decisions about palliative care versus a craniectomy.
Absolutely. Because neurological recovery is a multi-year marathon, and setting the baseline reality immediately prevents profound suffering later. You have to be honest.
Let's transition to the patients we do aggressively salvage. The bleeding is stabilized, the CT confirms no massive operable lesion, and we roll them into the ICU. Now the real war of attrition begins. Advanced neuromonitoring. First up, ICP monitoring.
Indicated for any salvageable GCS less than 8.
But the text directly addresses the BEST strip trial. This was the massive RCT that suggested managing severe TBI via clinical exam and serial imaging yielded similar outcomes to using invasive intraparenchymal ICP monitors.
This is a textbook example of why trauma surgeons must critically evaluate methodological limitations in surgical literature.
Break it down for us.
When BEST Trip was published, it sent shockwaves through the community. Some argued we should abandon invasive monitors entirely.
But you have to look at the protocol.
Exactly. The centers in the non-monitored arm were utilizing an incredibly intense, highly protocolized regimen of serial CT scans and continuous clinical exams.
Resources that most places don't have.
Right. The vast majority of standard high-volume U.S. trauma centers simply do not have the logistical bandwidth to replicate that safely.
So it was an artifact of the trial's intense resources, not proof that ICP numbers don't matter.
Correct. Major societies continue to strongly recommend invasive monitoring. However, the trial highlighted a vital philosophical shift. We cannot rely solely on a single global pressure number.
Because an ICP monitor simply measures the global pressure inside the vault.
It tells you nothing about local ischemia. You could have a perfectly normal global ICP of 12, while a specific area of cortical tissue adjacent to a contusion is actively starving for oxygen.
Which is exactly why the text emphasizes brain tissue oxygenation monitoring, PBTO2. We are dropping a probe directly into the white matter to measure the local cellular microenvironment.
The target is a PBTO2 greater than 20 millimeters of mercury. If it drops below that, you are detecting cellular hypoxia long before the global ICP ever spikes.
And how are we intervening? We can augment the MAP to increase perfusion pressure, but the text specifically points to guiding our packed red blood cell transfusions.
Because hemoglobin is the actual oxygen carrier.
Right.
The current recommendation for severe TBI is maintaining a hemoglobin between 7 and 9. If your PBTO2 is sitting at 14 and your hemoglobin is 7.1, that is a clear indication to transfuse a unit of PRBCs.
To increase the oxygen carrying capacity specifically for the injured microenvironment.
It is highly targeted proactive rescue rather than reactive pressure management.
Now we have to step into the ring for the most fiercely debated topic in neurocritical care, hyperosmolar therapy. Mannitol versus hypertonic saline. For decades, mannitol was the undisputed standard. You give 0.5 to 1 gram per kilogram. The mechanism is simple. It increases plasma osmolarity, creating an osmotic gradient that pulls water out of the swollen brain parenchyma, across the intact blood-brain barrier, and into the intravascular space.
The brain shrinks, the ICP drops.
But here is the massive problem with mannitol, and why I argue it acts like paying off a credit card with another credit card. You get temporary relief, but then the volume contraction hits and drops your blood pressure.
Right, the systemic volume contraction.
Exactly. You get immediate relief. The ICP number looks great for 2 hours, but mannitol is a profound osmotic diuretic. The kidneys filter it, water follows it into the tubules, and the patient massively diureses.
You have pulled the water out of the brain, but now you are peeing it all out, leading to severe intravascular volume depletion. The blood pressure tanks.
And what did we just spend 10 minutes discussing?
Hypotension is the primary driver of secondary brain injury.
It's deadly.
You are lowering the ICP, but by causing systemic hypotension, you are simultaneously destroying the cerebral perfusion pressure. It is entirely counterproductive.
So why on earth are we still debating this when hypertonic saline is available? I mean, HTS, whether it's 3% via a peripheral line or a massive 23.4% bolus through a central line, it achieves the exact same rheological and osmotic gradient to pull water out of the brain.
It does.
But crucially, because it is essentially salt water, it expands the intravascular volume. It supports the blood pressure rather than destroying it. It seems like an absolute no-brainer.
Well, the hesitation largely stems from the lack of a single, definitive, massive, multi-center RCT directly comparing the two with uniform protocolized dosing.
We don't have the big trial yet.
Right. There's also the theoretical concern about the reflection coefficient. Mannitol has a reflection coefficient of 0.9, meaning it almost entirely stays in the blood vessel, whereas sodium is slightly more permeable. So if the blood-brain barrier is completely destroyed, there is a fear that the sodium could cross into the brain tissue, reversing the osmotic gradient and causing rebound edema.
But the clinical reality and the recent meta-analyses don't bear that out.
They don't. The data clearly shows that HTS provides a more rapid, more robust, and more sustained reduction in ICP. It significantly improves cerebral perfusion pressure, and multiple meta-analyses suggest it decreases ICU length of stay.
So while the definitive trial remains elusive, the practice pattern in modern U.S. trauma centers has firmly shifted. Hypertonic saline is now the definitive first-line hyperosmolar agent.
Without doubt.
Let's look at metabolic control, keeping the brain quiet. We heavily utilize propofol and dexmedetomidine. They decrease the cerebral metabolic rate for oxygen, CMRO2, which in turn decreases cerebral blood flow demand and lowers ICP.
Right.
But the text explicitly warns about opiate use. We have to treat pain, obviously, because pain spikes sympathetic tone and ICP. But high-dose opioids can be incredibly dangerous here.
They really can. High-dose opioids, particularly fentanyl infusions, can cause a paradoxical compensatory cerebral vasodilation in some patients.
Wait, really?
Yeah, you're trying to sedate them, but you inadvertently dilate the cerebral vasculature, increasing the blood volume inside the pelican case, and the ICP paradoxically spikes.
That's wild.
Propofol is preferred because it reliably couples the reduction in metabolic demand with a corresponding cerebral vasoconstriction, tightly controlling the volume.
What about temperature control? In post-cardiac arrest care, we aggressively utilize therapeutic hypothermia to preserve neurological function. Does it translate to the traumatized brain?
It absolutely does not.
Okay.
And this is a critical distinction that often confuses providers transitioning between medical and surgical ICUs. In severe TBI, massive trials like POLAR and Eurotherm have repeatedly failed to demonstrate any functional outcome benefit from prophylactic hypothermia.
So it doesn't help.
Furthermore, they showed significant harm.
Oh,
Yet, inducing hypothermia in a trauma patient severely exacerbates trauma-induced coagulopathy and drastically increases the rate of severe pneumonias.
so what's the standard?
The absolute standard of care is strict normothermia. You aggressively treat any fever with cooling blankets and antipyretics because fever skyrockets metabolic demand, but you do not proactively chill these patients.
To close out the medical management, we need to touch on two highly controversial pharmaceutical interventions, barbiturates and steroids.
Barbiturates like pentobarbital are the absolute end of the line.
The last resort.
They are reserved strictly for refractory intracranial hypertension that has failed hyperosmolar therapy, failed deep sedation, and failed paralysis,
You are inducing a burst suppression coma.
completely shutting down all electrical metabolic activity.
Right.
But the cost is profound myocardial depression. The patient will require massive vasopressor support just to maintain a MAP. They are a last-ditch effort, never a prophylactic measure.
And what about steroids? In spinal cord injuries, high-dose methylprednisolone was the controversial standard for years. In neuro-oncology, we give dexamethasone to reduce tumor edema. Why not in TBI?
This brings us to the CRAH trial. Corticosteroid randomization after significant head injury. It was a massive international trial.
What were they looking for?
The hypothesis was that steroids would reduce the inflammatory edema and improve outcomes. The reality was a disaster.
What happened?
The trial had to be halted early by the Safety Monitoring Board.
Because the patients getting the steroids were dying faster.
Yes. The mortality in the corticosteroid arm was significantly higher than the placebo arm. And critically, it wasn't just driven by the expected steroid complications like GI bleeding or severe systemic infections.
It was something else.
It was an unexplained, direct increase in mortality. The evidence is definitive and closed. Corticosteroids have absolutely zero role in the management of severe traumatic brain injury.
Which is a perfect example of why we rely on the evidence, not just the underlying physiological theory. Okay, let's look at complication prevention. We are keeping them alive, the pressure is managed, but the ICU is filled with traps.
So many traps.
Let's start with seizures. The text notes a 4 to 7% incidence of post-traumatic seizures. Early seizures, within the first 7 days, are catastrophic because they massively increase the brain's metabolic demand at the exact moment it is most vulnerable to ischemia. Prophylaxis is mandatory.
You have to do it.
The two heavyweights are phenytoin and levetiracetam, or Keppra. The Brain Trauma Foundation guidelines still officially favor phenytoin. Why?
Primarily due to the sheer volume of robust historical prospective data validating its efficacy. Phenytoin has been the standard bearer for decades, and its acquisition cost is incredibly low.
But I'm looking at the modern prospective analyses cited in the text, and they show an identical seizure rate of 1.5% for both drugs. If the efficacy is exactly the same, why would any trauma surgeon choose phenytoin? It requires constant therapeutic drug monitoring, it causes significant hypotension when infused too rapidly, and the long-term cognitive blunting is well documented.
Which is precisely why clinical practice has rapidly outpaced the rigid guideline criteria.
Makes sense.
Levetiracetam avoids the cardiovascular depression entirely.
Yeah.
It doesn't require serum level monitoring, it has minimal drug interactions, and it lacks that profound cognitive suppression.
So Keppra is winning out.
The BTF guidelines require overwhelming level 1 evidence to change a primary recommendation. But the vast majority of U.S. trauma centers have already transitioned to levetiracetam as their primary prophylactic agent due to its vastly superior safety profile.
Next trap, venous thromboembolism. TBI patients have triple the risk of developing a deep vein thrombosis or pulmonary embolism compared to standard trauma patients.
It's the ultimate surgical catch-22.
It really is. You absolutely need to initiate chemical prophylaxis, blood thinners, to prevent a lethal PE. But the patient literally has an actively bleeding brain. The text weighs unfractionated heparin against low molecular weight heparin.
It is a terrifying tightrope.
Yeah.
LMWH, like enoxaparin, is generally much more effective at preventing VTE in the trauma population.
Right.
However, because its half-life is longer and it is heavily reliant on renal clearance, there is theoretical concern about an increased risk of microhemorrhage progression compared to standard heparin, which can be turned off and reversed rapidly.
So let me give you a tactical scenario, a listener question. You have a patient with a 4 mm acute subdural hematoma. You manage them medically. You repeat the CT scan at 24 hours. The subdural is still exactly 4 mm. It is stable.
Okay.
The medical intensivist rounds and wants to start enoxaparin right now. Do you pull the trigger?
You pull the trigger.
Really?
The text is unambiguous here. The overwhelming evidence demonstrates that the risk of hematoma expansion drops precipitously when stability is proven on a 24 to 48-hour repeat CT scan.
So you have proof it's not expanding.
Right. If you withhold chemical prophylaxis for a week out of fear of the subdural, your patient has a massive probability of dying from a saddle pulmonary embolism. You obtain the stability scan, and within that 24 to 72-hour window, you initiate the LMWH. Paralysis by analysis here costs lives.
Let's talk about the airway long-term, tracheostomy. The goal is always to get the endotracheal tube out of the mouth to decrease sedation requirements, facilitate pulmonary toilet, and minimize ventilator-associated pneumonia.
VAP is a huge issue.
In general trauma, early track, days 3 to 8, is almost universally preferred. But the text flags a massive controversy regarding early track in the severe TBI cohort.
Yes, recent retrospective data and smaller trials suggest we must exercise extreme caution. While early tracheostomy absolutely reduces the incidence of EAP, it has been paradoxically associated with an increased mortality rate in specific severe TBI populations compared to late tracheostomy, which is performed around days 10 to 14.
Wait, how does preventing pneumonia increase mortality? That sounds completely counterintuitive.
It comes down to the timing of the cerebral edema. Days 3 to 8 often represent the absolute peak of the cytotoxic and vasogenic edema. Intracranial compliance is 0.
So the brain is at its most swollen.
Exactly. Transporting that marginally stable patient to the OR, or even performing a bedside percutaneous track, which involves manipulating the neck, transient loss of airway pressure and PEEP during the tube exchange, and massive sympathetic stimulation.
All of that stresses the system.
It can cause a catastrophic, irreversible spike in ICP. In these highly tenuous patients, allowing the brain to declare itself and pass the peak edema phase before subjecting them to the physiological stress of the procedure is often the wiser course.
Wow, that makes a lot of sense. So we've maximized the medical management, we've navigated the ICU traps. But while medical management saves most patients, sometimes the pressure demands cold, hard steel.
Sometimes the medical management fails. The pressure continues to rise. That brings us to operative interventions, when the scalpel is the only option left.
Operative intervention is primarily indicated for extraaxial lesions, the epidural and subdural hematomas. They account for 75% of all surgical TBIs.
The mechanical goal is straightforward. Evacuate the mass lesion, stop the active bleeding, and expand the cranial vault to restore compliance.
And the texts provide very specific hard triggers for when we bypass the ICU and go straight to the OR. We are talking about a midline shift greater than 5 millimeters, a clot thickness greater than 10 millimeters, or a total hemorrhage volume exceeding 25 cubic centimeters in a patient presenting with a GCS of less than 9.
Those are your hard stops.
And the stakes are immense. Early surgical evacuation for a large hematoma can decrease mortality by up to 50%. Let's review the distinct pathophysiologies here, epidurals versus subdural.
Okay, so epidural hematomas are classic arterial bleeds.
Right.
The typical mechanism is a lateral blow to the head causing a temporal bone fracture, which lacerates the middle meningeal artery. Because this is high-pressure arterial blood, it violently dissects the tightly adherent dura mater away from the inner table of the skull.
This creates the classic biconvex or lenticular shape on the CT scan.
Exactly. And because of the arterial pressure, they expand incredibly rapidly, often producing the classic clinical presentation of a lucid interval.
The patient is knocked out, wakes up, and seems fine.
And then rapidly deteriorates into a deep coma as the arterial blood compresses the brainstem.
Whereas the subdural hematoma is venous.
Correct. As we discussed with our 78-year-old at the beginning, subdurals result from tearing those bridging veins. The blood accumulates in the potential space between the dura and the arachnoid mater.
So it's not constrained?
No, it is not constrained by dural attachments, so it spreads diffusely over the entire hemisphere, creating a crescent shape on the imaging. Because it is a low-pressure venous bleed, the expansion is slower, making it particularly insidious and lethal in the elderly population with atrophied brains.
What about intraparenchymal contusions, bruises deep inside the actual brain tissue? If we see a massive contusion, we don't just dive through the healthy cortex to suck out the bruised tissue, do we?
No. Direct surgical evacuation of deep intraparenchymal contusions is rarely indicated and often disastrous.
Why is that?
Digging through healthy, eloquent cortex to reach a contusion causes immense iatrogenic damage. You're causing more harm than good. Instead, if the contusion is causing massive swelling and midline shift, the primary surgical approach is indirect, the decompressive craniectomy.
Okay, so you remove a massive section of the skull and widely open the dura mater. You are completely unsealing the pelican case to allow the swollen, edematous brain to expand outward, rather than herniating downward through the tentorial notch and crushing the brainstem.
Exactly. You give it somewhere else to go.
But this brings us to the two most hotly debated trials in modern neurosurgery: DCRA and RESCUE.
Oh, these trials.
These trials look specifically at using decompressive craniectomy for refractory intracranial hypertension, and the results forced the entire surgical community into a profound ethical crisis. Let's look at the DCRA trial first.
So the DCRI trial evaluated early decompressive craniectomy for moderate intracranial hypertension, and the results were shocking.
Shocking how?
The patients who received the early craniectomy actually had worse functional outcomes at 6 months compared to the cohort managed strictly with optimal medical therapy.
Wait, really? But they lowered the pressure.
The surgery effectively lowered the ICP, yes, but the physical act of the brain herniating out through the surgical defect likely caused axonal stretching and further ischemic damage.
So the cure was almost worse than the disease. So we wait. Which leads to RESCUE, which evaluated craniectomy as an absolute last-tier life-saving measure when all medical therapies have completely failed and the patient is actively dying. What did RESCUE show?
It showed exactly what you would expect mechanically. Removing the skull as a last resort definitively lowers the ICP and significantly improves overall survival. More patients lived.
But wait, looking at the RESCUE data, what's fascinating here is the actual definition of success. We are saving their lives. The mortality drops. But a massive percentage of these newly survived patients ended up with a Glasgow Coma Scale extended of 2 or 3.
Meaning they survived into a persistent vegetative state, or a state of lower severe disability, where they are completely dependent on nursing care for every basic human function.
Are we treating the patient or just treating the ICP monitor? We are dropping the pressure, but we are leaving these patients trapped in devastated bodies.
And that is the most profound, heavy ethical burden a trauma surgeon carries. The trials lay out the raw data, but they cannot answer the moral question.
Right.
You have a 30-year-old patient with refractory ICP, with absolute certainty you can drop the pressure and save their life tonight with a craniectomy.
But if the initial injury to the brainstem was so devastating that they will never interact with their family again.
Is survival the correct outcome? The text emphasizes that the decision to proceed with a last-tier craniectomy must be heavily guided by early, brutally honest conversations with the family about acceptable quality of life, not just survival probability.
And if the family elects to proceed, if you are going to do the craniectomy, the surgical technique is paramount. The text is absolutely uncompromising on this. The bone flap must be massive.
Massive. Unilaterally, it must be greater than 15 centimeters in diameter.
We see residents wanting to take off smaller flaps to make the eventual cranioplasty easier. Why does the size of the defect matter so immensely?
Think about the physics of the swelling brain. It is like dough rising rapidly out of a bowl. If you create a small defect, say 8 or 10 centimeters, that massive edematous brain still tries to expand. It squeezes forcefully through that tight opening.
Right.
The rigid bone edges act exactly like a tourniquet. As the brain tissue herniates through, the low-pressure venous outflow tracts are instantly pinched off against the bone edge, while the high-pressure arterial blood continues to pump in.
It becomes incredibly engorged.
It causes immediate venous infarction, hemorrhagic conversion, and massive tissue necrosis right at the margins of the craniectomy defect.
So a small craniectomy is actually worse.
A craniectomy that is too small is objectively worse than performing no craniectomy at all. You are actively strangulating the brain. You must take off enough bone, frontotemporal down to the floor of the middle cranial fossa to allow the hemisphere to swell freely without shearing against the bone.
And you must perform an expansile duroplasty. You
Yes.
literally sew a patch into the dura to give it more room.
Opening the bone is only half the battle. The dura is tough and inelastic. If you leave it tight, you haven't decompressed anything.
Let's finish the operative section with the most devastating pathology we see: penetrating injuries, high-velocity gunshot wounds to the head. The overall mortality is over 50%.
And in certain trajectories, specifically transventricular or bihemispheric crossing the midline, the mortality approaches 100%. The kinetic energy transfer from a bullet creates a massive temporary cavitational wave that instantly destroys tissue far beyond the actual physical track of the projectile.
If a patient arrives posturing, with fixed and dilated pupils indicating the brainstem is already compromised, surgical intervention offers virtually zero benefit.
Sadly, yes.
But for the survivors, the operative approach is incredibly conservative.
It is. In the past, surgeons would aggressively track the bullet path, trying to extract every fragment of bone and lead. Modern military and civilian data mandate a totally different approach.
You don't chase the bullet.
No. Deep intraparenchymal extraction causes massive, unwarranted iatrogenic damage. The focus is strictly on superficial debridement of the entry and exit wounds to prevent infection, achieving watertight dural closure, and performing indirect decompression if a massive secondary hematoma develops. You leave the deep, inaccessible fragments exactly where they are.
This has been an incredibly dense, intense masterclass through the actual realities of TBI management. Let's pull all these threads together. As our deep dive into Wilson, Hoff, and Couture comes to a close, let's crystallize these protocols for your next shift.
For the critical care surgeon walking into the bay tonight, here is your evidence-based foundation to prevent secondary brain injury. Number 1, defend the airway with short-acting agents and strictly forbid prophylactic hyperventilation. Clamp your PCO2 targets at 35 to 45.
Number 2, abandon the old ATLS blood pressure dogma. Push your SBP targets over 100 universally and strictly over 110 in your elderly autoregulation-shifted patients.
Number 3, in the ICU, transition completely to hypertonic saline as your first-line hyperosmolar agent to manage ICP without sacrificing your intravascular volume and CPP.
And number 4, do not let the fear of a stable subdural cause a lethal PE. Trust your 24 to 48-hour stability CT scan and immediately initiate chemical VTE prophylaxis.
That's the roadmap.
As you walk into the trauma bay tomorrow, consider this. We are currently feeding massive amounts of real-time physiological data, from the specific timing of GFAP biomarker fluctuations to continuous, localized PBTO2 cellular microenvironment readings to beat-to-beat autoregulation indexes into advanced predictive modeling algorithms. How long until a machine learning model at the bedside, crunching millions of data points and calculating the exact probability of a GUSA of 3, dictates whether you call the OR for a 15-centimeter decompression or move directly to palliative care? The science of severe TBI is rapidly evolving from reactive pressure management to predictive cellular level rescue. The edge is continually shifting. Are you ready for it?